sarcoma, fibromyxoid sarcoma, myxofibrosarcoma. So everywhere, whenever there is a myxo, you have a lot of myxoid names. So this way, if you are finding a lot of myxoid changes or intervening myxoid areas, you should also think that, okay, probably I am dealing with something which also has a myxoid element with the name. So these things should be taken into consideration. Biological potential. What do I mean by that? The biological potential, अभी मैं एक twist दिखाता हूँ आपको. It's not something which मैं जादू दिखाने नहीं आया हूँ. Twist ये है कि I have one case which I will go on discussing with you. But before that, let me tell you certain patterns. So one was age-based differential diagnosis in your mind. Second was location-based differential diagnosis in your mind. Now the slide is under the microscope. You are examining it. You are looking at the cell types. You are looking at the stroma. And now try to find out what patterns are you finding in these tumors. So you may find a storiform pattern. Storiform pattern जब भी मिला हमारे पास differentials होंगे. क्या क्या? DFSP, fibrous histiocytoma, inclusion body fibromatosis, low grade fibromyxoid. So it's not, पहले हम लोग सोचते थे ना कि storiform pattern, it's benign fibrous histiocytoma, it's DFSP. So nothing is very unique. Not even earlier we thought that finding a herringbone pattern gives us a diagnosis of herringbone pattern, fibrosarcoma. So that's not like that. You may find many other tumors like MPNST, malignant peripheral nerve tumor, which will also show you storiform pattern and many others. So at least if you know what is the storiform pattern क्या है, ऐसा घूमा हुआ swirling सा आपको आप दिवाली में you light that क्या बोलते हैं उसको चक्री and then the pattern. So that pattern is storiform. You may have fascicular pattern, which is basically the bundle of spindle cells running from here to there. It may be short fascicle, it may be long fascicle, and it has got connotation. Particularly because I am confining myself to the fibroblastic tumor. If you look at the smooth muscle tumors, leiomyoma will have short fascicles while the leiomyosarcoma will have longer fascicles. The moment you start getting a leiomyoma, आप fibroid देखते हो uterus में बहुत बार, and if you are finding long fascicles traversing here and there, look for the mitotic count, look for the necrosis, because probably it is transforming into leiomyosarcoma. I would confine myself to the fibroblastic tumor, but one was storiform pattern, the other was fascicular pattern, the third is herringbone. Herring is a fish basically, probably from the Amazon river or somewhere. I'm not very sure of, but that's a fish जिसके बीच में there is a central spinal line and then some spikes coming out of that. And this pattern you can very well see down there that there is a central pale line and cells are trying to overlap and reach towards that central line. That's a herringbone pattern. Once you have recognized that herringbone pattern, you only have 3-4 differentials: adult type fibrosarcoma, infantile fibrosarcoma, and fibrosarcomatous DFSP. Fibrosarcomatous DFSP. Mind my friends, DFSP diagnosis is itself not complete unless you have ruled out any change in the DFS, because this is the intermediate grade lesion. Intermediate grade tumors have very good potential for being converted into a malignant or a sarcoma. जब DFSP में sarcomatous change आ रहा होगा, you'll again start getting longer fascicles, loss of CD34, the herringbone pattern. So some things are to be kept in mind while diagnosing. I will go to the other pattern, plexiform. Plexiform जब हम देखते हैं, plexiform is what? Like thick, tortuous, bundled thing. Plexiform. So you may get this pattern in the neural tumors, then you have to make a diagnosis of plexiform neurofibroma. You may have the same finding in plexiform histiocytic tumors. and you may also get tissue culture like pattern. This will be clearly showing you sparsely separated on a background of myxoid or edematous stroma, tissue culture like cells. The different cells are very less: nodular fasciitis, fibromatosis, and low-grade fibromyxoid sarcoma. Parasitic pattern. This has to be remembered. A vessel which is, आपको पता है ना कि इसको स्टैग हॉर्न वेसल बोलते हैं, स्टैग हॉर्न वेसल. तो स्टैग हॉर्न इज बेसिकली द रेनडियर विच कैरीज द, वो शांता का कार्ट को खींचते हैं. The stag horns are there branching, and you can see the vessels are trying to branch like the horn of a stag. And you may also have some soft tissue tumors, particularly the fibroblastic ones, which will show you no pattern. So it's not always that you are going to have a pattern, but if you are having no pattern, then too there is certain differences to be considered. Like if you are finding hemangioparasitic vessels and patternless pattern, you are probably dealing with a solitary fibrous tumor. So these things are to be kept in mind. The stroma I have already talked about. Myxoid stroma, the differentials to be thought of. Calcification, calcifying aponeurotic fibroma. बच्चों में abdominal tumor, lot of calcification, fibrous cells scattered in bundles or sheets, calcifying aponeurotic fibroma. पहले मायोसाइटिस ओसिफिकेंस को भी नियोप्लाज्म में नहीं रखा गया था, अब ये भी नियोप्लास्टिक लीजन में कैटेगराइज किया गया है. सो दिस वे you can take help of the age, the location, the cell type, the stroma, the pattern. We have 5 things now, and now we will move on to various other patterns. Like inflammatory stroma है तो आप inflammatory myofibroblast tumor सोच रहे हैं. You have lot of collagen, it's always fibroma, Gardner type or nuchal type. This I am not intending to read all this. I am just trying to highlight particularly for the PG, because this comes in the examination. Gone are the days when we had only benign and malignant soft tissue tumors. Now we have an intermediate group, and also in the intermediate group we have 2 subgroups. One is intermediate rarely metastasizing, and one is intermediate locally aggressive. So rarely metastasizing usually doesn't show, in a span of 10 years it will probably not show you any metastasis, but there are case reports, there are sporadic findings of having a metastasis in these tumors. Who thinks that inflammatory myofibroblast tumor will show someday a metastasis? We never thought of this earlier. So that's why reading the biological potential, biological behavior of these tumors led us to think of 2 different categories. One will be locally aggressive and one will be rarely metastasizing. Highlighting the role of immunohistochemistry, which I have always been emphasizing upon. As we have already talked about, you must rule out the common mimics starting from the 5 common panels if required. If you are sure that you are dealing with a soft tissue tumor, probably you may cut out from this panel of markers, but otherwise keratin, S100, SMA, CD34 and desmin helps to delineate a lot. For example, if you are finding keratin, say pancytokeratin, either it is a epithelial tumor or it's a soft tissue tumor with focal or non-keratin localization. Else, like S100 positive, what do you think of when S100 comes positive? Most likely neural. So once we have S100 positive tumor, we are probably dealing with a neural tumor, be it neurofibroma, neurofibrosarcoma or neuroblastoma or whatever. But remember, once it is malignant peripheral nerve tumor, it may be present very patchily, very focally. S100 is not to be relied upon when you are looking at MPNST. So with the basic panel, I will move on to the little advanced and useful markers to have. So एक हो गया basic आप हमेशा रखें जिसमें आपके पास एक साइटोकेराटिन, एक S100, एक CD34, एक डेस्मिन हो, एक SMA हो, which tells us SMA positive, usually smooth muscle. CD34 positive, most of the fibroblastic tumors. S100 positive, neural tumors. CK positive, mostly epithelial. But then these are few of the IHC markers which you may have in your lab, which helps in a great extent. आपके पास solitary fibrous tumor है, synovial sarcoma है, और आप श्योर नहीं है whether I should sign it out as fibromatosis or not. Beta catenin positivity in a correct histomorphological background will assure you that you are going right. You are dealing with a solitary fibrous tumor. So these are some of the markers like MUC4. MUC4 is very great. Low grade fibromyxoid sarcoma and myxofibrosarcomas are these two lesions, tumors, which will always confuse you. Probably Dr. Pranav is sitting here. He might have undergone some of the cases where you are always confused what to write it out. Fibromyxoid sarcoma दूं कि low grade LGFMS दूं कि myxofibrosarcoma दूं. And morphologically it is very difficult. MUC4 totally helps in it. Particularly if you are dealing with LGFMS, MUC4 is positive, sign it out. 95% of the cases with MUC4 positivity having myxoid and fibrous areas will be a low-grade fibromyxoid sarcoma. So having these certain specific markers will definitely help you out. TLE1, synovial sarcoma, no question about that. You have a herringbone pattern, you have everything negative, because you know fibrosarcoma is a diagnosis of exclusion. After you have ruled out everything, you think that probably now it is fibrosarcoma, and then synovial sarcoma again will give you a confusion with fibrosarcoma or SFT. Particularly SFT is very close to synovial sarcoma. TLE1 helps. Put TLE1, it is positive, it is synovial sarcoma, there is no question. So kind of these new markers, WT1 and desmin, we know that the desmoplastic small round cell tumor will definitely show you this positivity. Some genetic alterations are to be known, particularly for our younger colleague, which probably will come in your exam, will be asked as an MCQ, and also if you have a molecular facility at your center, you would be happy to perform these molecular investigations. And why molecular? Because mind my friends, despite having age-based categorization, location-based categorization, cell type, stroma type, patterns, morphological patterns, and IHC, there would be a group of tumors where you would still be confused. And misfortune lands on us when we receive a referred case. It has been already treated by different drugs. The patient has been carrying the tumor for more than a decade. Now you put those IHC also, they are not coming. If they are not coming, you have thought of a morphological synovial sarcoma, you have a TLE1 negativity, where would you go? Then you would have to rely upon the molecular alterations, and they are the signature alterations. For example, look at the solitary fibrous tumor. There is a fusion partner of NAB2 with STAT6, or STAT6 ka IHC bhi hai. So once STAT6 is positive, it is definitely solitary fibrous tumor, provided 5% of different tumors may show such changes. For example, TFE3 translocation is present in alveolar soft part sarcoma. We already know that Ewing sarcoma has the EWSR1 FLY1 rearrangement. So these things are to be known. Now I have a case here, 26-year male with neck mass. It was a subcentimetric lesion. Grew in, see the history. 2 महीने में subcentimetric से 2.5 centimeter का हो गया, and also showed some 8 to 10 mitotic figures per 10 high power field. What do you think it should be? A benign lesion? A malignant lesion? What? So if we only rely on one thing, would not help in soft tissue tumors. And here I must emphasize that despite having said all these things, soft tissue tumor pathology can be learnt with time. You have to commit some errors, you have to put some IHCs, you have to revisit these tumors, and then you learn, okay, this was basically that which looked to me like that. So you have to undergo this process. So this tumor is looking little rapidly growing and has kind of increased mitotic activity, and the tumor looked like this. Underneath the skin, we can see there is a myxoid kind of well circumscribed tumor, very busy looking. And then look at the this photograph down there. We have somewhat extravasited RBCs, and the tumor cells are having elongated spindles